About this marker, again, it's not, it's not just the gait regulation, it's the prefrontal cortex and emotions involved. So we think that there is much more to gait than just the motor regulation and the balance. So this is the dual task for those who don't do that every day, I guess, is like when you ask people to walk, you're measuring their gait speed, you're measuring the variability of their gait, but you can do that as a simple task where you just ask the person to walk slow, fast, but you can also do it while they're doing cognitive tasks. And this is Gait and Brain Lab. This is something that they do every day as part of the metrics to see how much does it cost the person when they're walking as they start pulling some of the resources toward thinking, right? So if I'm walking and texting at the same time, I am definitely pulling some of my resources. And that is the basis probably of distracted driving. As you know, like a lot of accidents happen when people draw attention to their phone instead of the road. So it does compete for attention, and dual task is a good way to stress that system and allow us to measure it. That concept has been useful, as you can see from the meta-analysis looking at gait velocity, both the simple and dual gait velocity, and how much that can help us predict cognitive change. So you can see that the simple task itself, single task, versus adding serial 7 or counting backward, that actually increases the predictive power of Gait. And again, a lot of the publication were coming from Manuel and his team. Now, moving toward depression, as you know, depression is also governed by brain networks. This is a complicated slide, but something to think about is the red and blue, and the fact that in the state of depression, areas like the dorsolateral prefrontal cortex tend to change into hypoactivity. So in a way, if you think about a person who's depressed who tells you, I just don't seem to be able to think, my brain is just not working. It's actually mapped on this network where you actually scan people in that state, and you do see that their prefrontal cortex is actually low in activity, and their emotional networks, such as the anterior cingulate, the orbitofrontal cortex, insula, it's actually hyperactive. So this is no longer a speculation. We used to, in fact, learn about this from brain injury, but now we can map it, of course, with functional imaging, and there has been a tremendous amount of work from University of Toronto, Helen Mayberg, when she was there, to map this network and see what happens to that network when people actually get depressed and when they recover from depression. So in late life depression, this is a model by Alexopoulos, who contributed tremendously to late life depression, shows that, those networks could be affected by so many different pathologies. So it's not really one thing. So in the concept that was articulated actually by Alexopoulos and Devin Dan, they talked about vascular depression, for example. At the time, they said, well, a person who developed depression in late life tend to have white matter hyperintensities, and they tend to have a cognitive slowing, so they called it the vascular depression construct. I think we learned since then that vascular component is definitely there and is very common, but also we know that even neurodegeneration can do that, like amyloid deposits, inflammation can do that, and also, of course, repeated head injury as well. So you all have heard about the syndrome of repeated concussions and how that in aging athletes can result in a syndrome very similar to this, where there's cognitive impairment, mood dysregulation, and so on. So there's multiple pathologies that likely going to contribute to interrupting these circuits, and of course it interact with frailty and medical illnesses as well. So at the end, just to summarize all this discussion, that if you want to leave here with three, I use this model in discussing with patients, that there's really three main networks that we actually can deal with directly in our intervention. One is the executive network that involve prefrontal area and parietal area. And this is active and firing when the person is focusing and trying to kind of, like what we're all doing here. Now, if you go and sit in your office and close your eyes and just want to free associate, then your default network gonna be active. And that default network is tend to be inside, so the anterior cingulate, posterior cingulate, and the insula. But it's really a default where the person, now if you leave from here and you have something on your mind, even when you try to relax, that network is gonna be firing differently. So it's not gonna be as relaxed. Now, what makes the switch happen is the salient network. And the salient network is the one that we care a lot about in both psychiatry and pain medicine. We have the anterior cingulate and the insula. And that network tends to shift your salience, right? Like, so it tells you that you're concerned about something because and you tend to start picking up on negative themes and not enjoying the positive themes. So that's, in a state of depression, we definitely see an overriding of the salient network where the person seem to be, as you can see from the arrows there, their salience to positive stimuli is lower. They tend to pick up on, and I mean, those of us who practice in psychiatry would know that you speak to somebody in depression and they tend to tell you all the bad news in their life. I treated somebody in this institute here, a very successful accountant, retired with a lot of money. And at one point, there was a transaction of housing market went down. He didn't sell the house in time. And then he started truly believing that he is bankrupt. And his wife kept telling me that we're not that bad. I mean, we made, maybe 50,000 less than we should. But he was stuck in that state of depression and psychotic depression to the extent of feeling that all bad news. And medication didn't do it. Literally took him 4 ECTs and he's back to life completely. Like he was just not even sure why he was thinking that way. He was telling me, I don't know why I thought that way, but I was truly believing that. So that's an example of how salience change and you get stuck in a negative salient state. So this is depression the way we know it. Now, something about motor function and anxiety and depression. There has been work across the lifespan in depression to show that there is some motor changes that happen when people get depressed. So this is a study, systematic review meta-analysis actually from the Netherlands to look at motor alteration as really a codified signature of the syndrome of depression. And they proposed that we should actually think about motor intervention and like helping people by activation. And this is not surprising because we know that depression could be treated by physical activation. This is something that we recommend usually for milder forms of depression. Now, psychomotor slowing, though, it was nicely dissected by the study that looked at, how do you, like we call it psychomotor retardation, psychomotor slowing, but it's actually not just one component. There's actually motor slower. You can actually measure the motor slowing. You can measure the cognitive slowing as well through speed of processing. But also there's a component of subjectivity when the person says, I'm just slowed down. I'm not, doing, and sometimes they're agitated and moving fast, but they feel slowing down. It turns out that when it comes to correlation, that motor and cognitive slowing seem to correlate with certain factors. Like, for example, motor slowing seems to correlate with female, gender, older age, a higher number of medications in general, higher BMI, while cognitive slowing with lower cognitive function, which makes sense. But subjective slowing is more related to symptoms. So in a way, it's always going to be a question whether the slowing that the person is perceived due to their mental state as part of that salient, negative salient, as opposed to actual slowing in cognitive function, which you can measure and gate. Slow gait has been described in late life depression. So this is a large study from Germany that looked at people aged 50 to 80, and they had several hundred people, 401 people. 81 of them had history of depression. They're not currently in a state of major depression. Now, they defined major depression as Beck depression inventory above 18. So so basically, on average, people who had history of depression did have some depressive symptoms, like 7.7, and so it will be considered mild symptoms compared to those who don't. But gait speed seemed to be consistently and significantly slower. Now, that raises the question whether it's actually a trait phenomenon. So a person who have history of depression, either they're predisposed to that slow gait or that the previous episode of depression have affected their brain in a way. So it became an important question whether it's a subjective or state-dependent versus trait-dependent. Now, when you look at those who have mild cognitive impairment and Alzheimer's disease and how much depressive symptoms can affect their gait, it didn't seem to add, to the, so in a way, it does confirm the possibility that it's not necessarily the symptoms, it's more like the trait. Like if a person already have the illness that affect their gait, maybe the state of depression doesn't affect it as much. So it's still something we need to sort out, but it's interesting that we didn't see, but this study, again, the caveat that they didn't have people who have severe depression. So we have to still look at, they only use the cutoff of 5 to 6 on the Cornell, which is very, very mild. I mean, as you know, in the Cornell, if you cross 8, you have a syndrome of depression, but about 5 or 6 is mild symptoms. So one thing that I became aware of is as you probably a lot of you know, that the Canadian longitudinal study on aging is a very important Canadian study that follow people over time. And there's data available. In fact, now there's always a call to mine that data and be able to analyze it. So one of our colleagues who's currently in McGill, Sekon, looked at the motor, and actually this is part of the network, the Gait network as well. I think you recognize, Olivier Bouchet, who Manuel knows very well. So he supervised Sekon on this. So they looked at the study data that start actually at age 45. So from 45 to 54 is kind of considered young old in a way, like middle age in my view. 55 and older, 65 to 74, or above 75. When you look at the motor complex risk syndrome, the fact that a person may have slowing down in their gait and they feel subjective cognitive impairment, that seemed to be actually predictive, prevalent actually in those who have depression in a way. So it's another signal that maybe midlife depression is something that we need to, but that signal seemed to have faded as people got older, which doesn't mean that it's not important as they get older, but maybe then it becomes part of that package of having mild cognitive impairment or dementia. It's not necessarily dependent on the syndrome of depression anymore. So we know for sure now that the depression in middle age is a predictor, but it's important to distinguish though between being at risk of developing a future illness versus having the earlier manifestation of that illness. So, being depressed in middle age might be a risk factor to develop cognitive disorder in old age. But when you develop depression in late life, usually within 5 years of the onset of dementia, that's part of the syndrome. It's not a risk anymore, it's actually an early manifestation. So when you think about late life depression, then it does seem to correlate with all-cause dementia, but the signal is stronger for vascular dementia. So while a person who developed depression in late life might be 80% more likely, or the hazard ratio of 1.8, develop a dementia of any type, it is 2.64 for vascular dementia. So it does give us now the possibility that the pathway is not always toward Alzheimer's disease. It could be toward, and actually, this is something that we, in clinics, we feel more that some people just linger in that state longer. I had a patient that I treated for probably 5 years and passed away before developing dementia, although I thought from day one that this person going to develop dementia. I think it was a vascular, because it had all kind of vascular risk factors, white matter hyperdensities. So not everybody going to develop Alzheimer's disease. Alzheimer's disease has a particular pathway, but a lot of us probably will have vascular lesions. And then we need to think about not just removing amyloid, which is obviously now a hot topic, but could modify through neuroplastic interventions to modify vascular risk factors. So just to summarize all this, basically we have depression midlife seem to be more of a risk factor, but depression in late life tend to be more of a pre-morbid or kind of early manifestation of the illness, I should say. And sure enough, if you have somebody who developed depression first time in their 60s, 70s, you start thinking about cognitive impairment as opposed to earlier depression that may not actually materialize. So that's still important. The depression state versus the trait and effect of that on gait. So we know that those who recover from depression in old age may still have slow gait. And then we'll have to keep that in mind as we navigate through this. So risk factor versus the manifestation I mentioned. There's something that now evolving in the neuropsychiatric symptoms of dementia. There is a dysregulation that happens, and I'm going to share with you some of the work that some of you know, Dr. Zainur Ismail from Calgary, who does the mild behavioral impairment. Mild behavioral impairment is meant to be identifying those who are even mild cognitive impairment, and what is the meaning of different symptom profile. So now we're leaving depression behind in terms of a syndrome that might have, we all deal with and treat in the middle age, that could be a risk factor for Alzheimer or vascular dementia, to think about early manifestation of cognitive disorder. So this is the mild behavioral impairment. It really speculates that the person do not have dementia today, but they have a change in their behavior in a way that is measurable. And what is the meaning of this is being really investigated very heavily now. And Zainur Ismail have been, in fact, he was a keynote speaker in the International Psychogeriatric meeting, talking about the meaning of a change in behavior. So all this used to be lumped under personality changes, right? Like a lot of us would have said a personality change in old age could be the beginning of a dementia, but now this is breaking down the signal. So if you have somebody who developed mild behavioral change, so the clusters that I'll mention to you here, there's the apathy is captured in the first cluster, which is lower motivation, lower ability to enjoy things, but it's not really depression. There you really, and I'll clarify that further. There's the emotional dysregulation. So this is when you have somebody with negative affect and anxiety, depression can be under that. And there's impulse control problem, blurring out and saying things that you shouldn't say. Of course, social appropriateness, psychotic symptoms. This is hallucination, delusion. So all these are clusters as part of the mild behavioral impairment, and they started showing more and more robust psychometric properties and predictive power. So you can see how in normal versus MCI, like in the psychotic cluster, for example, you cannot see psychosis in a normal person, while you can see it in MCI, and mood and apathy, and how that increases in the mild cognitive impairment. And so this is actually being more and more mapped across the journey of cognitive disorder. So a word on apathy and depression. As you know, this is an important question. When you see a person who have low motivation, low energy, no insight, psychomotor retardation, that could be depression, could be apathy. The only time that I call it depression is when I see the person expressing hopelessness, guilt, suicidal ideation. So you need to make sure that you're prepared to treat depression and find a way to treat it, but not necessarily push antidepressant on somebody who may have apathy. And apathy is actually, in fact, neurologists probably consider apathy as part of the executive dysfunction. It's low initiation, but it does have more and more dimension. Now, the reason why I'm mentioning this as well, that actually Federico and Manuel were part of this paper with Hachinsky and Elizabeth Finger, looking at the triad. And so we were talking about the triad of depression, gait change, and executive dysfunction. They published from the brain and gait and brain data set on the triad of apathy, call it the AGE, which is really about apathy, gait impairment, and executive dysfunction. And of course, the speculation there, you can't mention Hachinsky without mentioning vessels. So it was about the vascular supply of these key areas that has to do with initiation of movement, enjoyment of activity. So I think we are moving toward breaking down those symptoms and look at their predictive power. So we did actually a study when I was here. There was a study that we were running on depression, late life depression, and looked at dual task, where I mentioned earlier, between those who have late life depression, no dementia, those with mild cognitive impairment, and those who are healthy controls. And we did see that those with late life depression do have a specific, they're significantly different from both the healthy controls and the mild cognitive impairment. They do have a slow gait. So that, again, confirm the trait characteristic of late life depression that we have to keep in mind. Is that going to be modified by treatment? It's hard to know, because if you treat people, you're probably going to still have gait abnormality. Maybe you'll modify it to some extent, but I believe that it is a trait. Something that will summarize all this, that thinking, feeling, and walking really are part of a brain, and as the resources shrink, we're probably going to have to triage things differently. The signal of the stress can take away your resources and affect your gait and executive function. So this is the paper that was mentioned earlier about the triad, as Manuel mentioned, that it does seem to stand as a triad, very similar to the triad, the age triad. In fact, we're probably going to follow up and do the mood triad in the data set. I'm going to be talking to Manuel and Federico about that. There has been in that systematic review, in addition to finding the triad, that there has been some question whether exercise can improve things. The results have been mixed at that time, but I think since then we have more data and we can go back and see if exercise, in fact, I wanted to look at that in the synergic trial data as well. Exercise is likely going to be more helpful than antidepressant. This paper did get attention, and I think the letter that followed it raised the question whether this is a syndrome that could be studied. Now, one thing about antidepressants to keep in mind, that data from, this is from Brazil, showed that antidepressants, unfortunately, mediate the relationship between depressive symptoms and falls. So in a way, we likely causing some of the falls with antidepressants. So we have to balance that. I mean, I think people who are depressed and unable to function, and you treat them with antidepressant, you're going to improve their function. But if they're mild depressive symptoms, maybe exercise would be a better option to consider. This is the study I mentioned. It wasn't actually in depression. It was in Alzheimer's disease and agitation. And it was escitalopram for agitation of Alzheimer's disease. And despite the fact that we all considered escitalopram a safe drug and relatively benign, in fact, we went to this study thinking that we're probably going to avoid QT interval changes and cognitive changes. We discovered that QT interval continued to be a problem, and falls are higher in the escitalopram group. So, we have to think. I'm writing a paper now on the mechanism of falls in the escitalopram group, whether it's going to be cardiac because of the QT interval, or could be because we're inducing some psychomotor agitation. We don't know that yet, but hopefully the data will tell us. So knowing that, in addition to the exercise that I advocated for already, brain stimulation might be another option to consider. Now, you can't just assume that this will work for everybody, but there is definitely a good evidence of neuroplasticity and cognitive enhancement with repetitive transcranial magnetic stimulation in mild cognitive impairment and Alzheimer's disease. This is a review, I think it's a network meta-analysis that looked at the effect size. So we do know that these interventions, like for example, left dorsolateral, which is the most common target, high frequency stimulation. There's the right dorsolateral prefrontal cortex, low stimulation. So there's different paradigms being explored to look at different cognitive domains. And there's another study that looked at the physiology of when you actually give rTMS to people with depression, you're helping their depression, but you're also improving their executive dysfunction, and that seemed to map on the network of executive function in the brain. This is an EEG study from the CAMH group and their Japanese fellow. Manuel and I actually worked on this. This is a very early paper. It's probably our first paper together, looking at facilitating gait in a multiple sclerosis case. This person has particularly heavy white matter hyperintensities, and we still have seen significant improvement. So there is a possibility that in addition to improving executive function, we might be able to improve gait through rTMS. And we just actually got a paper accepted looking at that question, whether cognitive and gait effect in repetitive transcranial magnetic stimulation in late life depression is a reality. And we do see some evidence that rTMS improved memory and inhibitor control in older adults with depression, that gait speed increase with high frequency rTMS, and then domain-specific tools to detect, global tests like the MoCA or MMSE may miss some of the specific improvement, but if you look at speed of processing or trail B, you may see more specific. In fact, the Wisconsin card sorting would be an example of a tool that might be more sensitive to the effect of RTMS. So it seemed to be, first, it's a safe intervention, has some promise. We still have to refine how we're going to do it. This is an example of some work with brain stimulation that's published by Dr. Tariq Rajhi, our colleague who was at CAMH at the time, and they did combine not TMS, it was transcranial direct current stimulation, so electric stimulation with cognitive training, and they did see improvement, and actually over 6 years, people stayed stable. So it's a good cognitive stabilizing factor, but the effect size was higher for major depression. So it kind of raises the question whether major depressive disorder in late life could be a separate phenotype when it comes to cognitive. It's a cognitive syndrome unique that could be affected, again, by the vascular factors or neuroinflammatory factors. We are doing a study now. This is work that Dr. Adrian Espirito, who's from Philippines, back in the Philippines. He was a fellow at the time, and we designed a study now, before that, we did actually a study with Manuel and the group. They call it the NIPS study, or non-invasive brain stimulation study for mild cognitive impairment. We had 22 participants. In that study, we actually had bilateral stimulation. We did not get positive results in that study. We think it was because we just used a paradigm that was not as precise. We just used the high frequency, and we used 20 hertz frequency, which at the time I assumed the more the better, but actually a meta-analysis showed up later to show that the higher frequency, like the right frequency is 10 to 15. As you go beyond, you end up with saturation and you may actually lose the effect. So in retrospect, it was a lesson learned. I'm going to have to avoid that in the current study, which is the theta burst study we're going to be doing. So this is the paradigm we're going to be using. So anybody with late life depression would be eligible to come to our study. Will get bilateral sequential treatment, right-sided inhibitory to left-sided excitatory, and they'll do it all in 1 week. So they'll have 6 sessions a day. So the whole course of 30 will be done, and then we're going to measure their gait, cognition, and an EEG as well. So that's going to be part of our contribution to the field. So just to summarize then, I mean, I've shared with you a lot of thoughts that you're really curious to see if we can have a discussion about your kind of understanding of this and what are some of the areas that you feel like we need to focus on. But dual task gait can be sensitive and feasible to detect cognitive status and predict cognitive decline in older adults, as we know, have been confirmed. But late life depression, high risk of all-cause dementia, particularly vascular, and the evidence of dual task cause is actually intermediate in late life depression between mild cognitive impairment and healthy aging. There is an evidence for a triad of depression, executive dysfunction, and slowed gait that might be due to related mechanisms, such as the vascular story that we mentioned. Affective dysregulation versus affective deficit is something we need to debate. So a person that presents with apathy versus present with depression, we have to think about where do we focus? In fact, we are doing a study on apathy, TMS as well, so it's a kind of separate pathway to improve people's lives. And brain stimulation is now being explored as a potential neuroplastic intervention for depression, executive dysfunction, and gait triad. So this is going to be our attempt to provide some therapeutics. But don't forget exercise. I mean, cognitive training and exercise are currently available. I know that we have this center recruited a lot of people with that syndrome, mild cognitive impairment. I'm hoping that eventually we'll do a study in late life depression specifically, because I think they're going to be a good target for this. So I'd like to thank you so much for being here, and of course, would love to entertain any question or points of discussion. Thank you so much.
Dr. Burhan, thank you very much for that most interesting presentation. Late life depression, you presented that one paper by Dins, looking at all-cause Alzheimer's disease and vascular dementia with the increased risk of Alzheimer's disease and or vascular dementia in the presence of late life depression. This slide here. At the time of this presentation, 2013, these would be clinical syndromes. And I wonder what your thoughts might be now in this phase of biomarkers, where we are using amyloid, tau biomarkers, where we're using blood biomarkers, not only for Alzheimer's disease, but for also comorbid illnesses or comorbid neurodegenerative diseases such as alpha-synuclein and that sort of thing. I'm wondering whether knowing that information, whether that will influence the understanding of late life depression in the role of these diseases, with us being able to characterize the disease, not as a clinical syndrome, but by being defined by biomarkers. I wonder what your thought is about that. And the second question is the interventions, exercise you mentioned, and the TMS. What do you speculate, or is there any evidence that you've heard of what it does, if anything, to these biomarkers?
Yeah, great question. So I think the first one, as you said, the age of this paper now is quite old, and biomarkers were not a commonplace, and now we do see them. So there's, just for those who don't work in the area, the two biomarkers obviously that have always been with us in Alzheimer's disease, the amyloid and the tau, are now testable, and then they're detectable through, I mean, the blood test has significant role, but more certainty, I guess, through the PET and CSF markers. So today, you can't do any study really for Alzheimer's disease or claim that you're going to look at a therapeutic in Alzheimer's disease without proving that this is not just a clinical syndrome that you defined. You actually have to confirm the pathology. I completely agree that the literature up to date have really did not have the opportunity to entertain that question. But something is actually happening as we speak, where biomarkers are looked at across the neuropsychiatric symptoms. And one of the areas that have really accelerated so far is the apathy, where there is a correlation with tau, definitely PET tau in particular, more than amyloid, especially as you go to kind of older adults. The amyloid signal become less, correlated with the apathy, just because by then, I guess, things might have been too advanced. Like earlier, you can still see amyloid predicting apathy. As you go to the illness proper, like Alzheimer's disease and tau become important. So I think we're going to be asking those questions as we speak now. And in fact, some of the data requests that you're going to see for the Compass ND is to look for the opportunity to answer those questions. I don't think we're going to have the sample of major depressive disorder, because those are not necessarily included in, but definitely neuropsychiatric symptoms like depression. And as you know, Zainur Ismail and Krista and others who are interested in this are now submitting requests to see, could we answer those questions, profile neuropsychiatric symptoms based on the imaging data we have and the biomarkers. So I completely agree with you. I think, my bias that this is a network disease. If there's a way to map that network or map the pathology in that network, we'll be able to tell with more certainty. The relationship with vascular disease is much more straightforward, in the sense that if this network is disrupted, you're going to have the disruption of the, but then with amyloid, it's a little bit different, right? You may have amyloid and may not have the injury, so I think those questions definitely going to be very important to answer, and we have a bit of an opportunity to do that with the Compass ND. Now, the question about the impact of exercise and TMS on biomarkers, I think this is definitely an open question, because when we're doing exercise and we're doing TMS, we know that we have neuroplastic changes. So people have looked at BDNF and the kind of traditional markers of Could they affect removal of amyloid? I mean, there is definitely a hemodynamic response to TMS. TMS actually increases blood flow and increases blood-brain barrier permeability. So I don't know that today, but it's an interesting question to ask. The one thing also that I know that other neuromodulation interventions, like the focused ultrasound, is actually promising to open blood-brain barrier, because it's very specific to that function. What they actually have been exploring is to find areas that you want the drug to go to, and you do focus ultrasound. This is a work from Sunnybrook by Nir Listman and his group to actually get the drug. So I don't think it's going to be too long before they're going to start asking that question. Could we target specific areas of pathology rather than giving the drug everywhere? Yeah, excellent question. I think they started from the back. Yeah.
Thank you. I have a question about the sense of agency being involved in this process and localizing it to the temporal-parietal junction that combines the circuits of, the premotor, the sensory motor, and the prefrontal kind of cortex working on coordinating movement from cognitive to motor perspective. And then the sense of agency, I think, is like a twin to the salience in a sense, because you need both to do that. Mm-hmm. In one of my clinics with the functional movement disorders, we focus a lot on the lack of sense of agency for those patients who cannot control movement smoothly anymore. And it comes from wrong processing of the information coming in, and therefore not being able to adjust movement to the required environment. And that sense of agency, I think, overlaps into psychiatry. I think we talk about it as locus of control, mm-hmm. or sense of agency, loss of it in trauma and depression, that sense of hopelessness and like no control of self, emotions, life. I'm wondering two things: whether it's something that can be incorporated into part of your work, or do you already have it as part of your work, where the focus on, say, motor initiation, behavioral initiation approach, maybe the lacking piece is that sense of agency of movement. Therefore, mm-hmm. the gait is worsened and they can't do as much, or they sense like they can't. Yeah. And kind of working on initiation with that, because our approach would be distracting them from intentional movement and creating a reflexive automatic movement by pulling it away from the salience networks. But the other piece is, what if TMS, can that be targeting the parieto-temporal junction? And do you think that would mm-hmm. target some patient populations that maybe have not responded to the original location?
Did you say frontotemporal junction?
Temporal-parietal.
Temporal-parietal, yeah. So the, that really raises the question about the precise targeting of, TMS started as a very exciting idea that you can actually reach the brain without having to, open the skull. And those of you who have read some of the history of brain stimulation, like the very early brain stimulation happened in direct contact with the brain through brain surgery. So, Penfield and his group, when they were performing surgeries on epileptic patients to remove parts of the brain that has epileptic foci, they were actually experimenting with brain stimulation at the time. They used electric stimulation. And so what we are privileged to have now, which is the mapping of the motor and sensory cortex, is something that happened through brain stimulation. But of course, so when TMS came, it was very exciting. So the first story about TMS was motor. Everybody knew how to stimulate the motor and find out neuroplasticity. But then Mark George, who's one of the fathers of TMS, said, well, what about prefrontal cortex? What do we do if we stimulate it? Are we going to get something out of it? And some of the neurologists in that field were just not sure what to make of it. It's like, well, it's a silent area. Like, you're not going to get anything out of it. But so this is an example of how we found the dorsolateral prefrontal cortex. We found that it works for depression, and we got stuck with it all these years. It's the most commonly stimulated area, and does have definitely good efficacy in depression. But your question about, like, are there other targets, right? So there are some, in fact, there's a study that's very relevant to Alzheimer's disease by Koch. He's from Italy. You probably know him, Michael. He does neurophysiology of Alzheimer's disease, and he did a study in the posterior cingulate over a year in 84 people, those who have mild cognitive impairment, and he demonstrated that they have good, actually, effect size to prevent progression to Alzheimer's disease. So, target is really ours to work with. So if we identify an area that has to do with a function that we think, because brain stimulation is agnostic to the target, it's not agnostic to the way, the frequency affect excitation, how long you need to stimulate. All these are, neurophysiological rules, but you can definitely explore target. You mentioned self-agency, and one of the studies that was done here with a PhD student of Paul Freeman, we looked at TDCS, for example, and self-referential function. And again, in the posterior and the dorsolateral prefrontal cortex, we did see that people tend to have more self-agency when you stimulate one area versus the other. So it is definitely an open target for us. So I think initiating movement, whether you go to the premotor area as an example of an area that we use to get people moving. Let's say you have somebody with a functional neurological disorder and they can't move their arm, and then you actually can stimulate their arm. Could that give them the indirect feedback to say, yes, my arm is moving and now I can move it? So there's a lot of interesting things to do. The tool is very feasible and very safe to use. So I'm not aware of any specific study in this, but I know it's not, like the sky is the limit. Like you can really, now you can't go too deep. Going too deep require more, focused ultrasound can reach deep, but the TMS is only really cortex, up to 2 centimeters of the cortex, but different targets are welcome. We actually have treated auditory hallucination with the TMS on the auditory association cortex, tinnitus. Unfortunately, with these illnesses, you can sometimes have those who have chronic tinnitus that's not modifiable, but 50% chance of improvement is there. So yeah, there are more than one target. There's a question there.
Hi, Dr. Burhan. So, quick question. So, what are your thoughts on the use then of other interventions such as DBS or TDCS, and how would that be different to TMS, and why do you choose to use TMS?
Yeah. So, I mean, the study that I mentioned, cognitive training and TDCS, for example, that was one example of a study that used TDCS, right? So, the difference is very important to know that TMS is it's a very precise tool, like where you actually reach the brain, inhibit or excite by working with interneurons. So you can actually enhance GABAergic transmission and make it inhibitory, or enhance glutamatergic and make it excitatory. So what you're doing there is really working directly with the interneurons. You're shutting down depending on the frequency. With transcranial direct current stimulation, you're actually only changing the polarity. We're making the neurons under the stimulation side more likely or less likely to fire. So using electric, so you're pulling negative or positive polarity to make the sodium channels open or close. So that's more of an excitability change. So in interventions, like if you want to combine cognitive training or cognitive behavioral therapy, might be actually more feasible to have TDCS or transcranial direct current stimulation, because that will be something that a person could wear, and it's a 9-volt battery that's operating it, so it's not really that difficult, not disruptive, and you can get. We're still struggling with the timing. Like, do you need to prime, then get that going, or do you need to do it online? So these are all the questions that we have to ask. But in terms of mechanism, with TMS, you're inducing local current in the interneuron level, and you're changing excitability. With TDCS, you're basically pulling, making the charge polarized toward more negative or more positive, and that will allow the neurons under to be more likely to fire or less likely to fire. Yeah. But again, location will be of interest. Cathode versus anode will be different in terms of like positive versus negative. All these are consideration, but like anything else, it's all about your knowledge of the brain network and what do you intend to do, and test and see if the timing is right, or you need to change your timing, the frequency, the duration of the stimulation. There's so much that you have to work with. So modeling comes to, in fact, something we haven't talked about today is how artificial intelligence and modeling is going to help us with these things, because you can start by some observation in, let's say, 20 people, but you can put that in a deep learning model and it tells you much more in terms of what you should see. Then you can test it again and like improve your model. So I think we're going to be, even in clinical trials, Michael, I think I met somebody recently who's a chair of quantum artificial intelligence in one of the universities of Texas. And he's thinking that all these trials that require thousands of people may be shortened by applying on, like, you're still going to have a sample of maybe 50 people or so, but you can multiply that and make the trials much faster to conduct. So I think this is exciting that we're going to have cheaper way to get the drugs to people. Yeah. Mike?
Two things. Just, I wanted to check, we are checking to see if anyone online has questions. So I guess someone's checking that. We're not sure we can do that. Okay. We're not able to do that. Okay, thank you. I'm struck by this recent paper here, this one here, and two things about it. The slope of the lines, and I think I can see this. This is months across the bottom, I think. Okay, just, yeah, it is months. Yeah. So this is an 18-month trial, basically, and the slope of the lines are very similar to the slope of the lines that we see in people with the mild impairment and mild dementia with the disease-modifying therapies, amyloid disease-modifying therapies. The other thing to the right of the screen, which we can't quite see now, it said that was a larger effect size if they make the screen a bit smaller.
In depression,
the
remitted depression, those who had depression and remitted do not have a cognitive disorder. Yeah.
But it's a larger effect size in people who had remission of their depression, but also in non-APOE carriers. So non-APOE carriers would be people who would be less likely to have an underlying Alzheimer's disease for their dementia. So I think that this is where another thing where the biomarkers are going to be really helpful in knowing what you're actually changing at a biological substrate is what I'm interested in.
Yeah, no, it's a great point. I mean, first of all, it's actually 60-month, so it's a very long study. It's like this is years of following people and giving them. So everybody got cognitive training, and TDCS could be active, could be sham, right? So the person, how much we can enhance the signal. But the comparison was actually between those who have mild cognitive impairment versus those with the remitted major depressive disorder. And then they did have the APOE typing, and they were able to. So as you said, like in those who don't carry APOE4 tend to do better with this intervention. So again, just raising that possibility that we have to chase amyloid or Alzheimer pathology when it's there, but we can't assume that everybody's going to be destined that way, right? So we know that there's a possibility that we have vascular, but we also have TDP-43 in late life, late onset, So I don't think we're going to be able to do any study further without biomarkers. I completely agree with you. And this is like an opportunity that they had that data. Tariq Raji, I remember when they got this funding, it was a philanthropic funding, $10 million to conduct the study, and they did what they can do with it. COVID really killed it in the middle, but they were able to finish it. But I think today, you're right. Like, I mean, if I'm going to do anything, I'd like to know if there's an Alzheimer pathology, because the response rate have always been problematic. And you say, why do we have this limit? Well, that's because some people are on a trajectory toward neurodegeneration with Alzheimer pathology, and some people may have a static illness that could be improved. Yeah, so there's no doubt that this is where we need to go. Even in the behavioral studies, like I'm now part of industry kind of sponsored studies for agitation and psychosis. They're not compromising. Everybody needs biomarkers. So I can't just say that I have a sample of probable Alzheimer's disease. They want that to be confirmed. Yeah. Any other questions?
I think we have time for one more question. Okay, right. So
Thank you so much
No one
again
has
for
more
all the
questions.
interesting-
Now we're going to close the event. Thank you very much for your
Appreciate it.
presentation, very enlightening. Now Dr. Bori will give the plaque. Dr. Raymond.
Well, it's my pleasure to be able to welcome you back to Parkwood Hospital. Thank you very much for this most stimulating presentation, Amer. It's wonderful to be hearing the work that you've been doing at your new location on, I'm going to say Northern Shores. It's not Northern Shores, it's...
We appreciate it.
Yeah, and what I'd like you to do is to receive this plaque. It's really a recognition of your seminar for this 19th Gait and Brain episode. I've been to most of them, and that was the most stimulating talk, so thank you very much.
Appreciate it. Thank you so much. Thank you, everyone. Great, yeah. Yeah, so a lot of the requests get to come in. I think Krista and I work on the apathy and